Hello and welcome everyone to the part 2. Before we go forward, we will summarize a little bit about what we have discussed. That is, what are the possible phenotypes of AKI in patients with liver dysfunction, whether chronic or acute. The most common is prerenal azotemia, which can be because of the hypovolemia, and this is around 35%. The causes are laxatives, diuretics, decreased intake, and hepatocardiorenal syndromes. Next, you have HRS1, which is one of the most common diagnoses we make when we see a patient of AKI with chronic liver dysfunction. We have described in details the pathophysiology, how it happens, how there is a functional vasoconstriction and the liver dysfunction. Next is the ischemic acute tubular injury, which is around 25%. This happens when this particular state stays for a long period of time. So this prerenal azotemia staying for a long period of time uncorrected will result in ischemic acute tubular injury. And it can be also seen in cases where patient has upper GI bleeds resulting in hemorrhagic shock, or subacute bacterial peritonitis resulting in septic shock, and also acute on chronic liver failures. In all these cases, you will have ischemic acute tubular injury, and this is quite high, around 25%. So here you mainly look for these type of casts, to look for what is known as muddy brown granular casts, to look which are signs of tubular damage. Next is renal vein congestion. We have already discussed this, the reasons being acute abdominal compartment syndrome, portopulmonary hypertension, hepatocardiac renal syndrome, and this accounts for around 15%. So here you will see that the ascites is so much, the cardiac dysfunction is so much that the renal vein is totally congested, causing impairment in the renal perfusion. Next, you have toxic acute tubular injury, which is seen in cases like antibiotics, acetaminophen, cholemic nephropathy. Cholemic means because of bile acids and bilirubin, and this accounts for around 10%. Here again, you need to see for sediments. You will have renal tubular epithelial cell casts. This is sign of toxic acute tubular injury. Next is acute glomerulonephritis, where you will find cases of HCV, HBV. This is membranoproliferative type of glomerulonephritis, or cirrhosis associated IgA. In urine, again, you will find sediments like acanthocytes. Next is acute interstitial nephritis, which again is because of antibiotics mostly. Finally, you can have obstructive, which is because of nephrolithiasis or midodrine-induced urinary retention, like those things. But this is the overall classification, and to summarize, we start with this first. Next, we go on to our case, which was a 40-year-old man who has a history of decompensated cirrhosis. So he presents with hematemesis, and he has a history of portal hypertension and also varicose bleeding. In his current medication, he is on nadolol and norflox. His blood pressures are low. Please note this, his blood pressure is low, 85/45, and the heart rate is 110. Urine output is again low, 15 ml per hour. Physical examination is revealing jaundice, yellowish skin discoloration, spider angioma, hepatomegaly, ascites. Lab studies reveal hemoglobin of 6.6, sodium is 128, potassium is 5.4, creatinine is raised 3, the baseline was 0.9, urine nitrogen is 85, bilirubin is 10.5. Urine analysis reveals no blood or protein, but the urine sediment microscopy shows muddy brown granular casts and the leucocin crystals. The urine sodium is 20 and the urine creatinine is 80. What do you think is the most likely etiology of AKI? Is it acute interstitial nephritis? Is it bile cast? Is it hepatorenal syndrome? Is it ischemic acute tubular injury? Or is it prerenal azotemia? Now please note some things. The patient here has presented with hematemesis, portal hypertension and potential variceal bleeding. So it does indicate there is a severe GI hemorrhage because the patient is also in shock with decreasing urinary output, and apart from that the hemoglobin is also low. So the patient is in hemorrhagic shock. The things that point towards the diagnosis is the granular cast, that is muddy brown granular cast, which is ruling out hepatorenal syndrome. And mind you, bilirubin cast will be seen mostly if the bilirubin is more than 15. With a bilirubin of 10.5, it is unlikely that you will have bilirubin nephropathy, cast nephropathy. The fractional excretion of the urinary sodium is 0.58, and which is calculated from the sodium of 20, and the urine creatinine is 80 and the serum creatinine is 3. This does not really rule out the presence of acute tubular necrosis. Now, apart from this, the patient is on Norflox. So acute interstitial nephritis is unlikely because there is no fever, rash or leukocyturia. Next, if you look at the leucine crystals, they are common in liver disease and do not indicate any particular liver disorder or kidney disorder. Pre-renal azotemia could typically present with a bland sediment, mind you. That means there was no tubular damage or structural damage, but then we have seen casts which indicate there is a structural damage to the kidney, which means it is acute interstitial injury. So answer is ischemic acute interstitial injury. The suggestive is the hemorrhagic shock from the GI bleed, the presence of muddy casts, and which has effectively ruled out HRS1, and we have already discussed the other parts. So how do we manage this case? Immediate actions that you need to take is volume resuscitate with blood products, identification, ligation or cauterization of the bleeding blood vessels. The goal is to measures to prevent further insult rather than to revert what has already been done. So other causes of ischemic acute tubular injury in cirrhosis are septic shock with spontaneous bacterial peritonitis, toxic acute tubular injury, which is commonly seen with antibiotics like vancomycins and fluoroquinolones. The next case, it is a 60-year-old man who is admitted for progressive weight gain and dyspnea. He has advanced cirrhosis and refractory ascites requiring frequent paracentesis. His current medication is aspirin, omeprazole and spironolactone. His blood pressure is essentially normal, heart rate is 90. Physical examination is showing jaundice, spiral angioma, dullness to percussion at the right lower lung fields, tense ascites and 3 pus splitting edema to the hip. The lab studies show a hemoglobin of 9.6, serum sodium 128, potassium 4.5, creatinine 3.2, which is elevated. The baseline was 1.2. Urine nitrogen is 60, the bilirubin is 2.5. Urine analysis shows no blood or protein. Urine microscopy reveals bland sediments. Urinary sodium is 15, urinary creatinine is 80, and echocardiogram reveals left ventricular ejection fraction 60. The estimated pulmonary artery systolic pressure is 50 and the central venous pressure is 15. His bladder pressure is 27. Which of the following mechanism is most likely playing the role of pathogenesis in this patient? So as you can see, the patient has multiple pathologies here which can potentially lead. What according to you is the most likely cause of pathogenesis here? Is it the decreased cardiac contractility? Is it the extrinsic compression on the kidney? Or is it the ischemic tubular injury? Or is there hypovolemia and renal vein congestion? Now, this particular patient has advanced cirrhosis, refractory ascites, progressive weight gain and dyspnea. Physical examination, we have found tense ascites and 3+ pitting edema. and the creatinine has raised. The key findings here are the pulmonary arterial systolic pressure is elevated, suggesting there is portopulmonary hypertension. The central venous pressure is also elevated. The bladder pressure estimated is 27, which indicates there is an intra-abdominal hypertension. Tense ascites is a potential cause of intra-abdominal hypertension and abdomen compartment syndrome. Increased abdominal pressure translates into elevated the vein pressures, leading to venous congestion and impaired renal perfusion. Now, intra-abdominal hypertension also reduces the inferior vena cava venous return, preload and cardiac output, and increases the intrathoracic pressure, reducing the right ventricular contractility, all of which perpetuate the reduced renal perfusion. This patient's presentation of tense ascites, edema, elevated CVP makes hypovolemia unlikely. And obviously, since we have no casts and it's a bland cast, so the ischemic part is gone. So, what could be the potential cause? Here we make the diagnosis, which is renal vein congestion, which is due to the intra-abdominal hypertension and the cardiomyopathy. Increased abdominal pressure translates into the venous congestion. Intra-abdominal hypertension will cause the problems resulting in portopulmonary hypertension and the venous congestion. Cirrhotic cardiomyopathy can limit the renal perfusion and aggravate this condition. So, when you have a case like this, how do you manage it? You will do a large volume paracentesis associated with short-term improvement in the kidney function. The large volume paracentesis is not consistently linked in precipitating HRS1. Recent reports suggest that improvement in the renal function will result in improvement. Decongestion must be attempted with the paracentesis and diuretics. Patients with hemodynamic alterations associated with hypovolemia may not benefit from albumin administration over here. Now, coexistence of HRS1 in these cases can exist. Diuretics may be ineffective unless the hemodynamics are improved. By increasing MAP and vasoconstrictor only we can help here. The next is cholemic tubulopathy. Cholemic tubulopathy, that is cholemic nephrosis, obstructive jaundice-induced AKI, bile cast nephropathy, impaired renal function in the setting of cholestasis. The mechanism is that it is a form of toxic acute tubular injury. It is originally described in obstructive jaundice of patients with cholangiocarcinoma, pancreatic masses, and also reported in drug-induced infectious and alcohol-induced acute cholestatic hepatitis. The experimental evidence suggests that the bile acid, not bilirubin per se, is potentially toxic to the renal tubules. Bile acids can also cause the renal hemodynamic derangement and cardiac output compromise, leading to renal hypoperfusion. Intratubular bile casts support the injurious role of bile acids. Hyperbilirubinemia, that is mean serum bilirubin 27 plus minus 12 in biopsy proven cases can be seen. Greater sensitivity or severity of the hyperbilirubinemia linked with attenuated response to vasoconstrictors suggests that there is a parenchymal mechanism also involved here. So, the case that we are dealing with is a 55-year-old man with recently diagnosed pancreatic cancer and is admitted now with a new onset jaundice and abdominal pain. His blood pressure is normal, heart rate is 75, physical examination reveals a jaundice and diffuse abdominal tenderness. Lab data shows a bilirubin of 44, hemoglobin of 8.6, sodium 130, potassium 5, creatinine 4.5. The baseline was 1.1. Nitrogen was 70 and the urine analysis shows 2 plus bilirubin, trace protein and no blood. Urine microscopy reveals abundant renal tubular epithelial cell casts and scattered granular casts. His urine sodium is 35 and the creatinine is 70. The kidney ultrasound shows no hydronephrosis. What is the most likely cause of AKI over here? Is it hepatorenal? Is it ischemic acute tubular injury? Is it obstructive uropathy? Is it prerenal AKI? Is it toxic acute tubular injury? Now, this patient has recently diagnosed pancreatic cancer and a new onset jaundice. which is very high. That is, the hyperbilirubinemia is very high. You can see it is 44. That is very, very high. Urine analysis is showing bilirubin as expected. You are also seeing trace proteins, and also you are seeing abundant renal tubular epithelial casts and scattered granular casts. These findings strongly suggest there is a tubular damage. His urinary sodium and urinary creatinine give a Fe sodium of 1.7, which also points towards a tubular insult. Regarding cholemic tubulopathy, obstructive jaundice induced AKI is a form of toxic ATI where obstructive jaundice results in kidney damage. So, in this particular case, our diagnosis is cholemic tubulopathy. The patient has these features. We have already discussed this. The management here is prompt resolution of biliary obstruction can improve AKI depending on the duration and the severity. Regarding acute kidney injury and acute liver failure, the etiologies are 2 to 10% of this individual develop AKI. Acetaminophen toxicity is one of the most important things. Massive ingestion leads to the accumulation of the benzoquinone imine, which is a toxic to the renal tubular cells. AKI risk 2.4-fold in the AP intoxication compared to the controls. Acute alcoholic hepatitis, 28% of these cases develop AKI. Ischemic acute tubular injury may be predominant over here, especially because of the inflammation or the sepsis. Cholemic tubulopathy can also contribute, particularly if the bilirubin is very, very high, as in this case, which was 44. Hepatorenal physiology may coexist if cirrhosis is superimposed. So, coming to our next case is a case of 29-year-old woman who was brought to the emergency department with altered mental state. She was last seen completely awake 36 hours ago. She was recently evaluated by her psychiatrist for depression, and on examination she is lethargic, oriented only to person, and reported abdominal pain and 3 episodes of vomiting. Her medical history was only pertinent for depression. Her temperature is normal, pulse was normal, respiration and blood pressure are normal. Physical examination showed jaundice. Palpation of the abdomen disclosed mild epigastric tenderness. Labs reveal a hematocrit of 32%, leukocyte count of 9,000, prothrombin time of 28, INR of 2.7, and sodium of 140, potassium 3.7, urine nitrogen 34, creatinine 3.8. Baseline was 0.9, so it's elevating. The total bilirubin is 8. Aspartate, that is AST, is elevated, that is 3900. ALT is 1700, and the urine analysis shows 1 plus protein. RBC is seen 1 to 4 high power field, and white blood cell is 0 to 2. Her urine sodium is 25, urine creatinine is 50, and urine sediment microscopy reveals dark granular waxy casts. What is the cause of AKI here? Now, the cause first is acetaminophen induced tubular injury. Is it cholemic tubulopathy? Is it hepatorenal syndrome? Is it ischemic? Is it prerenal? Now, since we have already discussed most of the things, hepatorenal, you have a cast here. Again, prerenal, same thing, you have casts, granular casts, but these are not diagnostic of acute ischemic injuries. So, you do find evidence of tubular damage, but they are not correlating with these things. And with a bilirubin of just 8, it is unlikely that you can have cholemic tubulopathy. So, out of exclusion, the most common thing that remains is acetaminophen induced tubular injury. The patient clearly has a history of depression, so likely ingestion for suicidal purposes can be done. And creatinine is typical 1 to 5 days post ingestion. The management is NAC, recommended until the INR is less than 1.5. Though direct evidence for renal recovery is limited, still this is the only treatment available. Thank you for your patience, and in the last part we will discuss regarding transplant, electrolyte imbalances and renal replacement therapies in this particular cases. Thank you for your patience.